The STEREOPAC-trial is indeed focusing on a patient with a pancreatic cancer, non-metastatic patient with a borderline resectable tumor. So we plan to enroll 256 patients, and the patient received neoadjuvant treatment. So that's what we call the treatment that is received before the surgery. And currently what we propose in the trial is first to start with chemotherapy, which is the standard, and then if there is no progression, then the patients are randomized between two arms. The first one is to continue chemotherapy alone, and the second one is to add radiation therapy treatment, which is called isotoxic high dose stereotactic radiation therapy, plus the chemotherapy before the surgery, and to see if the outcomes can be improved for the patient. Borderline resectable disease, what does it mean exactly? So it's a disease which is still localized, so there is no distant metastasis, and there is contact with the major abdominal vessels, but they are classified as intermediary. So they do not exclude directly the surgery, but the surgery is more difficult to perform. So when you have a borderline resectable tumor, the risk is when you perform directly a surgery, it's possible to do it, but it's really highly difficult to obtain what we call a R0 resection, which is a free margin surgery. It means that we don't leave any tumoral cells inside or just close to the margins that are resected. So it's complex because we don't know exactly still what to do in this case of a borderline resectable tumor. There is no real consensus. We know right now that doing surgery directly is not the best option, but we don't know exactly what to do for the treatment before. So currently the standard is more chemotherapy, but here we want to investigate if the addition of stereotactic radiation therapy can improve the outcomes for the patient, because it's still dismal even after surgery. So it's indeed different because normally we don't propose this kind of stereotactic radiation therapy for the patient with borderline resectable disease. So it's a chance for them to have access to this kind of treatment. It's also new for radiation therapy because before we were using conventional treatment which were called radiochemotherapy, but it was much longer treatment, around 30 sessions combined with chemotherapy, and unfortunately the outcomes with this kind of treatment is not really good, so the clinical trial were a failure. So this is clearly a new option that we are currently investigating when we try to give in a few sessions, 5 sessions for this trial, a lot of doses per fraction for the patient, and the total dose is called ablative or nearly ablative. So that's what we call radiation therapy, which is aiming for a curative aim to try to ablate the tumor. So it's almost the same as a classical journey for the patient. We try to stick as much as possible to what is currently done for every patient, to not make a heavy road for the patient, because it's really important. It's not the purpose here. So the only difference is that, of course, there is some questionnaire that the patient can also try to answer to help also estimate the quality of life, which is also very important for the patient in pancreatic cancer. We had, if the patient accepted, some blood samples within the classical blood samples, and you have the addition if you are in the experimental arm of the radiation therapy, but as you have heard, it's only 5 fractions, so it's very short. And it's only 6 appointments, 1 for the simulation and 5 for the treatment, and there is no hospitalization. It's totally ambulatory. so it's not so heavy. The difference between the two arms, because it's also important for the patient to not too much delay the time until the surgery, it's of course not long, it's maybe a difference of 2 weeks, so it's very, very short. There is clearly almost no difference with a classical pathway. There is also a lot of augmentation. The classical one, of course, that you have a follow-up which is perfect, of course, because it's inside the study, so you have people who are there for you all the time. You have all the study coordinators which are available for you. Every teams are involved, and we have to strictly follow what needs to be done for the protocol. So, of course, it's always better to be inside the protocol, in fact. Yeah. There is a lot. So, if I need to choose maybe 2 or 3. So first, improve awareness for pancreatic cancer. I think really it's the first step. If people are aware of that, they are not too much afraid also of that, because sometimes it's the case even for the physician. And if you have the spirit with me and all the team who are working on that, on the field, that we can move things further and improve things, I think it's really a good start. And I think the second point will be also to raise awareness also inside every funders. It's already the case for anti-cancer fund, but it's really difficult, in fact, in pancreatic cancer field to obtain funds, even if it's a huge burden, and it will be increasing and increasing. So we have to perform research. It's important for the patient, but for doing this research, we need money. So it's crucial. So currently a STEREOPAC-trial is open in 17 Belgian centers, which is already quite a lot, but we still want to improve it if we can. But it's highly complex, because it's not like breast or prostate cancer, which is much more frequent. Even if pancreatic cancer is more and more present, unfortunately, its incidence is constantly growing. It's still not at the point of having so many patients to study and to recruit and to participate to study. So this is the main issue when we are doing clinical trial, particularly for pancreatic cancer. It's to recruit the patients. Because there are a lot of hospitals in Belgium. It's not possible to open a study in every single hospital. It costs too much of money and it's too heavy. But yeah, we cannot be there, but still we want to attract every patient who can really participate, because we have to change things, and it's really important, and we really need to push forward and move into networks. Its complexity, and also the fact that there is so much to do for the patient. That's really the 2 main points, I think. It's a challenging pathology, a challenging disease, but it's really important to study, to understand the disease. How does it work? We know currently that there is different subtypes of this kind of disease, so we need to identify them, and so that we can also propose more personalized treatment for the patient, because currently it's not the case. Every patient just have exactly the same. And also which is really important for me to study is the resistance, which is totally within the scope of pancreatic cancer. And pancreatic cancer is definitely associated with resistant to chemotherapy, radiotherapy, to immunotherapy. So it's really difficult, and it's really the goal to understand why it happens, how we can take advantage of the different pathway. And it's also quite rewarding when we are doing new strategies, and it works not on everybody, but it still works. On some part we can see it clinically, And really, it's really rewarding for the patient, but also for us that, yeah, we see that we move and things are moving and it's for the best. It's slow, but it's moving.